Thank you so much, Lisa. So nice to meet everyone. Lovely to see lots of faces around the room. My name's Katie Hennessy, and I'm joining you today from the traditional and unceded ancestral territories of the Lekwungen peoples, including the Esquimalt, Songhees, and WSÁNEĆ nations of the Coast Salish peoples. Grateful to be joining you today across BC. So Kara and I, we're shaking off our nerves. We've done this presentation with some of you at the All Together Symposium, but today is really more about sharing our experience and then really hoping to have a discussion at the end of today. So we have some time for that. So today, what we're hoping to do is sort of understand, share with you, allow you to understand our approach that we used for this transition in moving Cowichan Hospice House from long-term care operations into community health services in the Cowichan Valley. Identify and share with you some of our system challenges while we undertook this transition, and then just create discussion about thinking creatively and collaboratively with lots of different partners, because as you'll see through as we talk about this, we had lots of people to engage with, more so than we anticipated at the start. So I'm just going to start by sharing with you some background of Cowichan Hospice House. And I do want to acknowledge that some of the work leading up to the culmination of Cowichan Hospice House development started long before my time with Island Health, and I think Kara's as well as the manager of Hospice House. So I do want to acknowledge and give deep gratitude for everyone who put in a lot of work and to make the Cowichan Hospice House come to fruition. And I can see some of the faces on this Zoom call, so really grateful that you're here, and just thank you for your hard work. So Cowichan Hospice House is one of hospices in the Cowichan Valley, and it is attached to Carensmore Lodge, which is a long-term care facility, in fairly close proximity to the current Cowichan District Hospital. So with that, the community came together, really driven by the Hospice Society and in partnership with Island Health, to develop a dedicated hospice for the Cowichan Valley. And it is beautiful. I encourage you, if you ever get a chance to go online and look at some of the videos or see it, it is just, it's a beautiful facility. And you can see a lot of the love and dedication that went into that development. So it's a 10-bed hospice, but initially we had funding for 7 beds. So at the inception, it was opened with 7 beds. While that opened at the beginning of the pandemic, which of course is another feat in of itself, some of you may know that we have a current Cowichan District Hospital that is serving the Cowichan Valley, and it was desperately in need of new builds. So they did undertake the feasibility studies and the approach to developing a new Cowichan District Hospital, which was set forth and in motion and is currently slated to open, I think, fairly soon, and I believe 2026, maybe sooner than that. But even with that, I think doing a lot of, the environmental scans, they did a lot of deep dive into the data and realized that with the growth that the Cowichan Valley is experiencing, even with that new hospital and more beds, that's still not going to be enough to meet the needs of the community. So with that, they undertook the Cowichan Health and Care Plan and really looked at the population in the Cowichan Valley, did a deep dive into who is this community? What is it showing us? Who are the people coming to hospital? Why are they coming to hospital? And how can we look at meeting these needs in the community? So with that, the Cowichan Health and Care Plan was developed. And what that showed us was that there was a lot of people dying in the hospital that were in acute care that were already supported by community health services. So that was, that showed us that the palliative population in the Cowichan Valley needed some dedicated services and dedicated attention to really look at what was sort of driving some of those numbers. Along with that, I think as we all know throughout COVID, there were some operational challenges in a lot of our long-term care facilities as far as staffing recruitment and, the ability to kind of continue to keep beds open because of staffing, and that, that did really impact Cowichan Hospice House. So we had to really look creatively at potential solutions, like different ways of approaching this to really sort of meet the needs of the Cowichan Valley. So in partnership we really looked at kind of how we could do things differently, like thinking outside the box. How do we continue to grow our hospice and meet the needs of the community, keep our beds open, have dedicated palliative care hospice staff, and improve the end of life experience for clients and the families? Those are really a lot of the drivers behind this, because we know a lot of the people that were ending up in acute care, that, that wasn't part of their, that wasn't their end of life goal. They did not want to die in hospital. And really look at why that was happening. We know transitions in care have been challenging, not just within Island Health and care settings, but we know this is a big piece of healthcare. So how can we make those transitions better? How can we improve this experience, not just for the patients and families, but for the clinicians, and really alleviate some of that distress that comes along with that that communication, those barriers in communication as we're in a hybrid system, and really support this sort of one team, my team, motto that we sort of have in Island Health, and make that more seamless for not just patients and families who are the ultimate drivers, but definitely the clinician supporting. That was a big piece. So with that, kind of setting the stage there, I'm going to hand this over to Karen. She's going to take us through some of the next little bits.
Thanks, Katie. I just wanted to add, you had mentioned the hybrid, and really we were striving for kind of a hybrid nursing model where we could support palliative clients in their home if that's where they chose to spend their last days, or in the hospice if that's what they chose as well, or they just couldn't manage at home, as opposed to going into the hospital. And so as part of that, we looked at staffing models that we could develop in the community. So we had to look at the staffing model at hospice for starters. So we knew we wanted to expand to 10 beds. We had that ability, and we wanted to staff it accordingly. So we had to look at what staffing model would be appropriate, and we chose one RN and two LPNs around the clock so that every shift had those three nurses to support the clients or patients. And we also were looking at the staffing models in the community as well, because initially we wanted to support people in their last 12 weeks of life at home. And then that could be their first option. And then if needed, then we could bring them into hospice as needed. We also wanted to have some dedicated leadership for hospice to help support this transition. So they brought in myself as a community manager, but we also brought in a CNL 7 days a week to help support the staff. We did have to collaborate with many different programs, including many different teams in community, the Palliative End of Life Program and the Cowichan Hospice Society. We wanted to make sure that we all had a really good partnership going on, and that we were able to facilitate this as seamlessly as possible, and to communicate this to our community as well, so that they were more aware of what resources were available. As far as communication goes, we needed to actually look at how we were going to communicate and collaborate with all the teams. So as far as sending out those communication memos and letting all the teams know, a lot of change management had to be involved with all the teams as well. This team in hospice, they were a 7-bed unit. It was one RN, one LPN, and they always worked with the same nurses for every shift. So they were kind of used to just the two of them able to facilitate. And when having a manager and a CNL come in that had more of that, were present more often than not, then it kind of was a little bit of a change for them that they had to get accustomed to. We also had to look at all of the programs that were helping to support the hospice. So that included the pharmacy, because at that point we were dealing with a community retail pharmacy, housekeeping services, food services, and all the interdisciplinary teams. And then what this would look like for the systems as well. I don't know, Katie, if you could go to the next slide. So as part of it, of course, we did come up with some challenges when we did that whole transition from long-term care. So because it is a facility that is attached to Carensmore, it's still considered Carensmore long-term care in a lot of the systems. So even though I'm as a community manager and covering dealing with the operations for it. It is been a little bit of a struggle as far as those systems that we deal with eye health and PSLSs and WorkSafe even for staff. So we had to look through all that. There was also licensing because we are followed under residential care. We follow that licensing. So we had to get all of that changed over under me. There was also some of the operational considerations too. It was attached to long-term care. It had a long-term care manager and was able to kind of move staff back and forth if needed. If they were short in one area, they could bring somebody over. And when it came under community, then that changed. We no longer had that ability to do that. And we thought, in our being very I want to say a pink cloud almost. Like we thought we
Rose-colored
would just,
glasses.
yeah, we just thought it would be easy that we could get our community nurses to actually come in to work at hospice as well. And then we quickly found out job descriptions are an issue between based on community or facility. So that really played on where the nurses could go to work. So we had to find ways to mitigate that. Luckily, because I do work a lot with the community teams, and have a good relationship with them and the nurses. A lot of them actually came on as casual to hospice as well. So they were able to kind of do that back and forth a little bit. I had to look at as far as even for my notifications for PSLSs or WorkSafe incidents or anything like that. Because I follow community programs as a CHS community manager, they give you a certain type of access to all these systems. And then as a long-term care manager, they give you access under that. And the views are quite different and do look different. So every time I ask somebody to change something so that I could facilitate and have actual good coverage for the hospice, it would revert me to a long-term care manager and then I'd lose other accesses. So it was kind of a fight back and forth with that part. And that has taken a lot of work and a lot of mitigations and a lot of communicating with the teams. I quickly also found out policies and procedures. So, community, we do have a lot of policies and procedures. We're followed by our community resource team, CRT, and I reached out to them to see what help they would be able to help to support our hospice in the community, and quickly found out because we are deemed still a facility that their policies and procedures just weren't appropriate for here. So that part there still had to remain with the long-term care to meet our licensing for that. The
I just
others,
want to add in, Kara, if it's
yeah,
okay, just to
yeah.
share, like a lot of this, it wasn't that to just to, it was no, we hadn't done this before. No one had done this before. So even a lot of people we took the questions to when it came to a lot of the systems pieces and the policy and procedure, everyone had to kind of pause and think about,
Mhm.
well, actually, I don't know. So it sort of just everyone, as everyone wanted to be so supportive. And I think that was everyone knew the sort of North Star, the greater goal, but we had never navigated these systems like it truly was, pioneers in some of this stuff.
It definitely was. And the systems there are set up a certain way. So unless somebody's going to go in and completely revamp the system, then you're kind of stuck mitigating certain things and developing different strategies looking outside the box. The other part that we had to look at too was for occupational therapy or dietary services, right? When they're attached to long-term care, they were very clear on who that would be to support that. And when it came under the community umbrella, we had to look at that a bit differently. So I had to develop a plan with the CHS here to agree to do those referrals to the community to have an OT come in if we had to order special equipment or to do training with staff so that they're able to order some of this equipment themselves. And then as far as dietary, we don't actually have a community dietitian here on the island. So that was a little bit of a challenge there. So I did reach out to acute care initially and they weren't able to facilitate, but luckily I was able to speak to their manager and we did end up keeping dietary services through long-term care. So even as far as the rehab or the special disciplines, you still kind of having to go in between different places depending on who can facilitate. Luckily, we do have RTs in the community, and we've been able to facilitate RTs coming into hospice to help support our clients that way, which has been absolutely great. Uh, Trying to think of any of the others. Overall, I think we made it work. It was just about communicating. And Katie, you're right. Everybody had the same goal. We knew what the intention was, and we know it needs to best be able to facilitate the transition for patients between care. It is ideal where it's sitting because you have that communication amongst the teams between acute care, community, the end of life team, the hospital, even. So, because we're able to be in a lot of conversations, we're able to help facilitate those challenges. Um, I think,
Yeah, and I think just as far as the team dynamics, like there was just it was just a lot of new, like we said sort of earlier, just more people with trying to work together to kind of make this work, and
mhm,
changes from long-term care staffing to CHS, but it, still sort of that in between about, well, that we can only be in facility, and new roles like with dedicated sort of management and CNLs for a hospice that can help with access and flow. We had to, I think the whole teams and all the sort of priority partners had to kind of take a step back to kind of look at and sort of redefine those roles and realize, actually, I don't need to hold all this. We can do this together, or you can, so really lots of looking at processes and kind of trying to, come up without feeling excluded, right? Because I think all of us on this call know how invested we all are and care so deeply for the people that we're serving. So always want to be a big part of that.
for sure. And I think part of it too is job descriptions too, because of course everybody here was under the long-term care job description. And to try to get them to look at that differently, I'm still working on that. And it's been almost 2 years. It's the RN was easier to do because we already had a job description that's being used in Victoria for the palliative response team in the community. And that job description is actually one that works for both facility and community. So that kind of was good for our RNs because then it does allow us in the future to have some potential to have that back and forth. The LPNs, however, it's a little bit harder to get job descriptions for them that's appropriate. So they unfortunately right now do fall still under the long-term care, which again does play a factor too on how you get people hired to hospice. Because on the V hire, which was another system issue, it looks like all the job descriptions were for the long-term care Karens more, not for actual hospice. So I had to actually do some communication and advertising through emails to different teams just to ensure that people knew what these positions were actually for, so that we're able to maintain staff, and we have. And as far as the team dynamic too, when we expanded beds and we brought in another LPN, that was actually 6 new positions here, part-time positions, and to have 6 new bodies to a very well-established 10 who only work with the same person every shift. So this added quite a dynamic change for the unit. And I did take a little bit of time for things to settle out. But overall, I think it was worth it for sure. We have managed. We are under CHS umbrella. They do have dedicated leadership. We have definitely improved the transition and mission process. We have been able to facilitate people to get into hospice very quickly as soon as the palliative end of life team sees somebody in the community and see that they know they're struggling at home. We don't want them to go to hospital. So they come right to us and we're able to facilitate that right away. Um, so that's really helped. We've actually had a decrease in hospital deaths because of this as well. As earlier, Katie had stated that with 30% of CHS clients were dying in hospital that were admitted for palliative. And we went actually a few months in 2024 where we had 0 deaths at the hospital. So that was actually quite astonishing and amazing there. And we have been working as far as getting community programs with the Hospice Society's help to bring in community so they're able to come into hospice for groups, for meetings, and just even tours, just to help normalize it. a little bit, right? Normalize death, normalize the hospice care, and get people engaging a little bit sooner.
Facilitate those conversations. Yeah.
Yeah, for sure. And I think it's been absolutely fantastic.
Yeah, and one thing I want to call out too, which I'm just grateful for the dedicated leadership at is that they have that on weekends. Like that makes a big difference.
Mhm.
There's a CNL at hospice 7 days a week. And we're really grateful for that. We don't have that at any of the other sites and on the island, but just that, hoping that that's something we can take forward in the
And
future
that
for
actually
sure.
we have
But
been
that
able to even admit people on
admit on the
weekends
weekend,
that they
which
planned. And as long as we have the medication orders and medications available for them, then yeah, we have been able to facilitate that. Actually, even recently on Christmas Day, they admitted somebody to hospice and New
mhm,
Year's Day, which are the 2 days that you would not think any movement would happen.
yeah.
So it just really shows for the team.
Yeah. Oh,
But
the
yeah,
lessons.
a lot of patience for sure. A lot of thinking outside the box, figuring out how to work systems. Communication has been a big factor and collaborating with all the teams and definitely more patience. I like how that's put there. Um, and perseverance. I mean, it has been a huge factor for our community that we are able to get people to spend their last days where they want to, as opposed to where they're forced to. So I think that that is a big factor with our community, home care, nursing, palliative team, our hospice team. We're just able to streamline those processes. And I really, really am grateful that we were able to do this for the community.
Mhm. Great. So I think, as the journey's still not over. I think we're over, like we're on the other side of it. Like, I think definitely on the other side of it, but there's still stuff to do. Kara mentioned eye health earlier. So eye health, for those of you that don't know, is our electronic health record. And there's so much tied to it that we don't even know, even when you think you're a paper-based system, which currently, it's sort of we've got a lot of our sites that are a bit of a hybrid, and so there's lots of things on the back end, and still we're still reviewing pharmacy services that are going to be overtaken sort of by acute care, and that's going to add another layer. So when we think of something that's kind of going by CHS policy procedure, long-term care policy procedure, and then we've got acute care. So trying to really um, align all of those to support our teams and realize sometimes how complicated the electronic builds can be, and especially to meet the unique needs of the hospice population. But definitely, I think we've learned so much as we've gone along that it's easier to kind of keep moving along with like being really solution focused rather than kind of feeling like, oh, we can't do this. It's, you know, just there's a way to do it. We just have to figure it out and connect with the right people. And again, it's a lot of people, we don't know what we don't know. And that's the same for the other teams like IMIT or the informaticists. Like, well, this is new to them too. So just a lots of let's trying things out, creative problem solving. Um, and I think, just the awareness, like you said, Kara, earlier, like the community that the Cowichan Valley is serving, just having more options, more conversations, more understanding of what is available on their end of life journey, and what can be there to support them. Um, and I think it has spoken volumes with, not just the extra layers of supports that have been putting in the community, but even just with the dedicated hospice team and leadership. I think, the experience isn't just improved for the patient and family. I think even the clinicians all involved, just, they, it's, it's positive. I think that's a lot of the feedback, and we're able to kind of really work and address some of the things that might be a little bit crunchy a lot quicker. Yeah, I think
For sure. And I
that's
think one of the benefits too, especially with the palliative end of life program, is we have she's not called a social worker anymore. What's her title now?
psychosocial, palliative care
Psychosocial.
psychosocial consultant.
They've started working with the Hospice Society where they've actually developed a drop-in center for the caregivers, so for the nurses in the community and hospice to come together in a safe space where they can have those difficult conversations with each other and not have their management or leadership present. It's just them as a community, which I think is absolutely fabulous in showing the partnership as well.
I think that's sort of it to start. We just want to sort of open up for questions and discussions. I'm seeing that there was lots of stuff in the chat, but I can't quite see that I just see it bubbling up. So I'm not sure, Lisa, anything that we want to.
Yeah, so are you ready for questions now?
Yeah, for sure.
Okay. So what we can do is if you have a question, you can unmute yourself, and then we'll take it from there. And then I will jump in with questions coming from the chat if you haven't been able to ask your question.
Should I stop sharing now, Lisa, just so we can, or do you want me to keep anything up?
No, you can stop sharing and we can just go ahead with the Q&A.
I have a question. Sorry. I don't
Yeah.
know. I'm Jenny, Sunshine Coast Hospice Society. I thank you very much for sharing. I'm really curious to learn more about this model. I'm particularly interested in what learnings you had in the change management process. We're kind of in a different circumstance here. We don't have a hospice home here. We are building one, but it sounds like there were many moving parts with the different organizations you were working with. And I'd just be curious to know what learnings you have in this phase that maybe you wish you'd known when you started this on the change management side. Just, really short,
Yeah.
easy, snappy
Well, I
question.
will confess that at the beginning of this, I was actually new to management and I was definitely new to change management. So it was a lot of trial and error for sure. We were lucky in the sense that we all met like at the director level between the palliative end of life program, the hospice society, community, and long-term care. We all met and had a plan in place to how we were going to share. So how we were going to share as far as the staff at hospice goes and how we were going to share with the community so that everybody kind of had a little bit of a heads up and what the goal was for it, for sure. Um, I will admit that part of the change management, because there was so many moving parts, that sometimes the communication never happened in a most timely way to the people that you intended it or it should have been. We find out after the fact, and then of course lessons learned, and we try to get everybody up to speed at that point.
Think you
But
forget how quickly word flies when there's change so like despite, a communication plan or what would we would think would be the excellent communication going out, there's that swirl, right? And there's so many different groups that were involved, I think, and just um, I think trying to be as transparent as possible while exploring different things too, addressing different and creating space for people to share their concerns, wonders, right? And just trying to be as transparent as possible was something I think we all definitely tried to be with what we knew, but it was a bit hard when there were some things unknown because you don't want to cause alarm and you don't want to create that fear, but we really tried to stay on top of some of the swirl of sort of the rumor mill, right, of concerns about, oh, we're not going to get this or this, but yeah, I think just creating a space for and creating that culture of sort of safety for people to feel like I have some questions about this, how can I bring them forward. That was a big piece, I think, just allowing people as to bring forward their concerns without feeling like they were anti-change, because it wasn't. I mean, we forget that in our healthcare systems there's so much change happening all the time, but I think just being really gentle and respecting and honoring how invested people are in this, right? It's really does bring about how patient and family centered everyone is from their perspective, right? So yeah, that was a big thing. I don't know if that was helpful, Jenny. Just transparency in change management and the why. Like I think that was sort of the why is another big piece.
So you didn't bring a consultant in or anybody to.
Well, there was no money for that.
Yeah.
Yeah. We,
Yeah, I mean we're probably different because maybe
yeah,
we could build it in, but yeah,
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 yeah.
no,
No,
we're like,
it
here we
was
are. Okay,
us figuring it out as we go. Yeah.
thanks.
Wouldn't say that would be a bad idea though, if there's funds for that,
Definitely.
for sure.
I would have
Yeah.
appreciated it for sure.
Yeah, definitely.
Congratulations on what a complex and challenging process it's been. Like it's, obvious. One wishes it could have been managed from community from the start, but congratulations on that big process. I'm interested in because really this nesting of hospice beds and long-term care is a provincial model that we're living with across the province. But I'm interested if how you might see this in other communities in island health, where there often may be fewer beds, but do you see this model as transferable or translatable?
I think it is, but I think it's about getting the buy-in for it as well.
Mm.
And I know it's hard for facilities and building, right, where the funding comes from, because I do know, is it 3 long-term care facilities right now that are being built on the island that are long-term care, and they're all having hospice units attached to them, hospice houses. So when I look at that, I'm thinking, okay, they must be still going to be following the long-term care model, but I'm not really sure. Katie, you might know something
Well, and I
different on
think that
that.
that's what we're still trying to figure out is like, absolutely, I think this model can be replicated. And, we have somewhat of a version of it in Port Alberni. Again, each hospice on the island is very unique. But I think it's probably very community specific. Like I wouldn't just say blanket statement that it would
Mm.
be, yes, let's do this everywhere because some some things are working really well in our hospice societies. And what we've I think learn or not hospice societies are hospice clusters. But I think what we've learned is like the different ways we can work within the systems that we have and really trying to kind of like, sometimes it is pushing the boundaries of really like breaking down some of the silos. So yes, this is long-term care, or yes, this is community, but it's one, we're all serving the same person. So, I think I I wouldn't be surprised if we replicate this model in different places, but I wouldn't say that everyone would necessarily welcome or need the type of model that we had, just depending on what the community is, what their long-term care site is like, what other supports are available, how involved the hospice societies are, and I think that there's still, knowing that we're still a fair ways away, like we're still in the design phase of the new builds that are coming. There's still discussions about what this looks like, what the staffing models look like, and there is still lots to come. Like with the minimum nurse patient ratios, that's going to impact things too, right? So those are lots of, I think, still ongoing conversations. And yeah, hope to, this has been awesome, like just to see how this has worked and like that it can be really successful, which is great. And I think that that's where, we've got lots of opportunities, but I think it would be really, again, kind of doing a lot of what Cowichan had to do. What are the needs of the community? What are we seeing? How can we make this work together? So but thank you, Gretchen. I do want to acknowledge I know you were a big part of the Couch and Hospice Society. So thank you for all of your work that went into this as well. Like, it wouldn't have been done without you.
I have to say I'm loving the Cowichan estuary painting behind Kara there. It's nice to see some of those things. Yeah.
Hey, any other questions? Feel free to raise your hand.
I think there's a lot of questions in the chat.
Yeah,
So
I can. If no one has any questions at this moment, I will go to the chat. Okay, so we've answered Jenny's question. From Joelle, her question is, if a person outlives the 12 weeks and seems stable or even has rallied, what would happen to the person in terms of care, especially if they could no longer manage to return home?
Okay. I'll take this one, Kara? Okay.
Sure.
So within our hospice admission process in Island Health, we do have written in, and conversations do happen with families that if if somebody does start to stabilize, and we think that they may live past that 12-week marker, which, I mean, we love to see that. We love to see that people surprise us all the time, that they may transition to long-term care. And so they go on once we've and we don't always wait that full 12 weeks. Like if we see after 4 to 6 weeks, the picture's changing a bit. They do go, they do get their assessment and go on the ALC list. And it's kind of it's treated sort of like the community patients, and we do work closely with long-term care. It really depends on how full the beds are and how, it can be really dependent on each community. I can't say a blanket statement, but for the most part, we do get them on the ALC wait list. There are times that they do end up dying in hospice, and there are times that they do get transitioned to long-term care. So it's I wouldn't say it's a 12-week exact because we know that the waits for long-term care, but that is sort of what our process is, and these are ongoing conversations that we will have with families.
I agree. I'm just going to add to that because of the fact that we are under the community and I have such a close relationship with that team, it has actually helped in the sense that when we do have those that end up stabilizing and needing to go for long-term care, we can quickly get a case manager in to do that initial assessment. And we know how long-term care the wait list is long and it takes quite some time. And there is a process in place that when we are full, we can try to expedite things so that we are so for example, right now we're full. I have one person waiting long-term care and two that need to be assessed, and we have a few in the community that really need to come into hospice. So we're trying to expedite things right now. So it does allow for a little bit more ease to have that conversation, I think, than it would have been before when it was attached to long-term care. I think it would have taken a little bit longer.
Yeah, and we have escalation pathways and different people that would get involved depending on is there community needs for the beds, all that sort of different things. So it's multifaceted for sure. But that is part of our, those conversations do have to happen. Somebody comes in, just that if things, just that nuance right from the beginning that if things do change, these are conversations we're going to be having with you.
I will also add, we've had the ability here under the situation that if we do have a few empty beds and somebody needs to come in for just a short-term respite or a little bit of symptom management, that we're able to facilitate that. And then we've had people that stabilize and are able to go back home and do fine for several more months before they end up coming back. So
yeah, we do
I
have
think
that.
that's just saying, I think that's a really key piece of sustaining caring at home.
Caregivers,
There's
100%.
Options for respite.
And I wish, I wish it was kind of like pre-COVID or almost, or at different places we could have a bit more of that sort of booked and planned sometimes, but in our hospice clusters, but the demand is so there that we don't see that. But I do know that long-term care is back facilitating sort of those booked and planned respites, and sometimes they do have palliative clients in those beds. And I do think that's a huge piece of sustaining caregivers, giving them that break when they need. And we will facilitate if we have beds available, 100% a respite stay, because we know how much that can benefit people to being able to go back home.
Okay, so the next question I have is from Kathleen Yu. Do residents in long-term care die in those beds, or do they transfer to the hospice?
No, we don't. Long-term care, when they're back at long-term care, they stay in long-term care. They give excellent palliative care in the long-term care home. So that's sort of we don't. There's not. There's a word for it that I'm forgetting, but we don't generally do interfacility transfers once from long-term care into hospice because they can be well supported in their long-term care site.
Great. So our next question is, could you please share what psychosocial support looks like for the patients and families? And did this change with the transition to CHS?
Care, do you want to speak to this a bit more just with the partnership with Cowichan Hospice on site, or?
So I'm not sure if that piece actually did change a lot with that transition, just because we already had support through the palliative end of life program and the hospice society, and we did maintain that after coming to community.
Yeah, I don't think that there has been much change sort of in that other than like I think communication between the teams, the team itself is probably more fluid and able to be a bit more responsive, just being that, that much sort of tighter and that many more people involved. But we do our regional palliative and end of life teams have a palliative care nurse consultant, psychosocial consultant, and a palliative MD in each of our communities. And as well, we do work really closely with all of the local hospice societies, and they're all are slightly different. And Cowichan is a pretty very robust hospice society that has a lot of psychosocial supports as well. So
great. So from Terry Weber, this is our next question. Does your community also provide shift care nursing for people who want to die at home but are now needing 24/7 nursing care for the last days of life when care needs can change quickly and can be particularly overwhelming for families to manage, even when there is a response team to help support them?
Definitely. So for us, we have 24/7 home support in place that if somebody needed it for that, but for palliative specific, we do have palliative home care nurses that we brought in as well for this program that they have day, evening, and I even have an overnight team. So there is 24-hour a day coverage to do the stop-ins or the PRNs or anything like that, but not a
but
nurse
not
to be able
nursing.
to stay in the home the whole time.
And yeah, and don't really do sort of respite. Sometimes the overnight LPNs can do short bits, but it's not, we don't have that, it's not a 24/7 nursing model. But those were extra, that was part of the Cowichan Health and Care Plan. They did bring extra, they dedicated lines for palliative nursing for the last 12 weeks of life to really increase, because the literature shows that increased supports during the last 12 weeks will help facilitate, those home deaths and support caregivers, so that, increase the visits in those last 12 weeks as much as you can predict the last 12 weeks. We know none of us have a crystal ball. But that also, along with the bigger picture of the Health and Care Plan, they also brought in other resources for like the COPD, because that Cowichan Valley has the highest population of COPD patients in Island Health. So, dedicated resources to help manage that. So it was like that really big picture of looking at the highest users of the hospital site.
Okay, I see, Brianne, your hand is up. I'll just get this question from Sarb. Is a psychosocial consultant hired by hospice or the health authority? And is it an MSW position?
Yeah, so our psychosocial consultants are with our regional palliative and end of life program. So that's with the health authority. And again, I mentioned, yes, we have them in our various communities up and down the island where we have our palliative regional teams. And yes, it's Masters of Social Work. And then I think the hospice societies generally have, and again, it's a bit different across the island depending on where you are, but they have counselors and some have social workers that sort of enhance a lot of those supports. And we are forever grateful. And I wish there was more that I know it's not just on me, but that the health authorities and the ministry can do to really, really beef up these, the psychosocial supports across the board, because we know how impactful they are and how much of a difference that they make in people's journey.
Great. Brianne, if you want to unmute and ask your question.
Yeah, I'm just curious. So these nurses that would serve, so it's all CHS, so are they part of CHS and seeing other clients if they're not seeing the clients? And so it's the same staff, which is good for continuity because they may see those nurses at the hospice. I'm just trying to get an idea of the flow. Yeah.
So the flow in the community, so the additional palliative home care nurses that have been brought in, they only do palliative visits. So once a client becomes, more complex or, closer towards their end of life and require those increase in visits, then they will see them more regularly and take over support for that.
And are they on standby then, just sitting at the hospice, or?
No, they are
Oh, they're
actually
based in
in community.
Oh, they are.
Yeah,
They're
they
Okay.
are
community. Yeah.
teamed with
That's
home care nursing, like the regular
okay. That's
nurses.
what
Yeah.
I was wondering.
Yeah. They
Okay.
just, so basically somebody comes in as palliative, they're automatically, say they're referred for palliative care, but they're home care nursing.
Yep. Yep.
And then
Yep.
once home care nursing has assessed them or deemed that, their
Things are changing.
things are changing and they need some more support, then they'll let those other nurses know who will then go in and
Help beef
follow
up the
up.
supports.
Yeah.
Yeah.
And
Beef
then
up the
for
visits.
okay,
Yeah.
that's amazing. And then for the flow into the hospice, like I know a lot of facilities will do direct admissions. I'm wondering how it is easier and if you have a wait list often.
So we do have a referral list. We don't call it a wait list, but we do have a referral list because it's all based on need. We get referrals from community and hospital. So of course, if community needs it, so say we have two people, they require the same needs, but one's already in hospital, we're going to leave it because they're already looked after. We'll take the one in the community first for that. And our CNLs basically help coordinate and facilitate with the palliative end of life team and the CHS team. So basically, they will make sure that we have the referral, that palliative end of life benefits are in place, we have the proper most, all of the orders are in place. And then once we have the orders for medication, we do have a contingency here now so that we can, if they are just only on end of life meds, we could facilitate them coming in without getting their personal meds first. But usually we would get the orders and fax them off to the pharmacy. So honestly, they could find out in the morning about somebody in community that's declining and really needs to come in, and they would be here by the end of the day. There are always certain instances where there can be delays, especially so our clients or patients here are followed by either community physicians or the palliative physicians. So because it's both, the palliative physicians were it's easy to get the orders needed and stuff in a timely manner. If it's a family physician that plans on following them in hospice, sometimes it can be challenging, as you know, just to try to get what you need from the family doctor to get them in the same day. But we do our best to try to facilitate.
Could you use the community end of life order set to just continue over if they had that ordered and just use that in your hospice?
If they have it, a lot of times they don't, though.
Okay, okay,
Yeah.
okay. And what is the coverage for palliative care physician at your hospice?
We have two palliative physicians in Cowichan Valley.
They're not dedicated to the hospice though,
No.
Brian. They just work in the same capacity as all of our
Okay,
physicians
okay.
across the
Yeah.
island. Yeah.
Okay. Oh, interesting.
They just tend to sometimes be MRP a little bit more than in Cowichan than some of the other sites. But again, it can be really dependent. And that's why each community is so, so unique. That's why it's that kind of hard to always replicate the exact same thing depending. But yeah.
Okay, anybody else have any questions? We've got about 5 minutes left.
Sorry, I have another question. I assume there is spiritual care and music therapy. Like just when I'm looking at that psychosocial question, I'm just wondering if you can elaborate more into the psychosocial supports.
I know that the Hospice Society does have some volunteers that come in and will play music for our patients, but we don't have the resources at this point, unfortunately, to have somebody on site that's able to facilitate that. And spiritual care, we do have people we can call in, but again, we don't have anybody here.
We don't have dedicated spiritual
Yeah.
health for the hospices or community, which is something which we would love. Just
Mhm.
grateful that they've recognized the need for acute care too, and hoping that that spreads faster than a snail into the rest of healthcare.
Just a comment that there are other hospices that have music programs that they can bring into those beds, but it does one of those things that a hospice society can fundraise for and support with a combination of professionals and volunteers often.
Anybody else? So we've got about 4 minutes. Katie and Kara, I don't know if you want to post your questions.
Oh, I just think I accidentally closed that slide, Lisa. I'm sorry.
Oh, it's
I
okay.
don't know.
I can ask. I have them here.
Yeah.
Okay, so Katie and Kara also developed 2 questions. So first question is how could you see this type of model for hospice care being utilized in your area? And are there any ideas people could share on how to navigate some of the system barriers that come up when trying to transition to this type of model for hospice care? Any thoughts about these questions?
I know some of you guys have already shared some great insight, so.
Okay. Well, if there's no other questions, we've got about 4 minutes. I can close the session if that's okay with everyone. So I'm just going to scroll here and I don't see any hands.
Everyone's probably grateful for a moment to run to the washroom before their 1 o'clock or something this afternoon. So.
Okay, so nothing in the chat. Okay, so thank you very much, Karen and Katie, for today's presentation discussion. Wonderful presentation. Thank you so much. So to everyone that attended, we hope you enjoyed this session and that you complete a short survey. It'll pop up when you leave this session. Registration information for the next session in this series and other echoes will be made available to you via an echo registration email newsletter outlining this month's and next month's series and sessions. So just so everyone's aware, AIM is to provide everyone with a copy of the presentation, recording, and session summary notes and other resources to you within the next 7 days. So just watch your email for this. So thank you again for attending, everyone. Again, fantastic presentation. I learned so much myself, and I hope you enjoy the rest of the afternoon. Thank you, everyone.
Thank you.
Thank you. Thanks for making